Hey guys, Dr. Nate here. So today's video is going to be packed full of information as I'm going to be breaking down what goes through my head clinically when I have a patient that has numbness, tingling, burning, pain going into their hands. So we're going to break it down starting here all the way down to figure out exactly where the problem is. All right, let's get right into it. Yeah. Alright, so I'm going to try to keep this simple but also informative, so none of this goes over anyone's head. They can understand it and they can break it down, but it's also a lot of information to pack in. But let's start out with why is it important. So let's just say numbness, for example. Numbness is our nervous system trying to talk to us, tell us something's not right, something's not getting its nerve supply. Numbness can lead to weakness. Weakness can actually lead to muscle wasting. Another thing that's important to realize is there's three words. There's myelopathy, radiculopathy, and neuropathy. So myelopathy is the actual compression of the spinal cord, whereas a radiculopathy is coming from the nerve root. Say you have a disc or some issue at the nerve root where it's exiting the spine. And then a neuropathy is a very general term for any other peripheral nerves, peripheral just being other than the central nervous system, the spine, any nerves out here, that would be considered a peripheral nerve. All right, so me clinically, anytime we're dealing with a nerve entrapment, even if it's just like these fingers right in here, I want to start with the spine. The first thing I do is I rule out the spine because it can present in a lot of different ways with your central nervous system being in there and things that can be affected. So we want to rule out the spine. So I look at the neck and I can put it through different positions. There's different orthopedic tests. I won't get into all of that, but I want to rule out that there's not a disc that's pushing on the nerve root. There's not IVF, just where the nerves exit the spine. There's not encroachment on that. If there's something with the neck that I can put it in a certain position and it reproduces the symptoms in my hands, then it's likely coming from this area. Another thing is the anterior and middle scalene, and I'll put a picture up, but the anterior and middle scalene, the nerve roots actually exit between those two muscles and they can get entrapped there if there's spasm. There was someone that wasn't responding well to just cervical manipulation, so we looked at the anterior middle scalene, did some muscle work, and it got rid of the numbness and tingling going down their hands. So while we're talking about the spine, there's what we call a dermatomal pattern. Like I said, won't get too much into the details, but it can actually tell us specific levels of the spine that are affected, even without an MRI, and they're pretty specific. So C5, you'll have some sensation out in this area. So C5 will refer in here generally. C6 will go down, and you'll have it over here. C7's more in the middle. Sometimes we'll go into the hand, and like I said, I'll put a picture up, and then C8 out here, T1 in here. So that's just for the upper extremity. That tells me different spinal levels that can be affected. And so we're going to start here, and we're going to move down. And the next place that I like to look is the shoulder for something called thoracic outlet syndrome. So thoracic outlet is, there's a bunch of nerves coming out of the neck, and they go in here, and like I said, I'll put a picture up, but a lot of times people will round forward, they'll close down, and they'll clamp down on a lot of the nerves, and there's actually a giant artery, the subclavian artery, subclavian vein running through here. So as our shoulders round forward, we start to clamp down on that. So a big factor in this is the pec minor under here can get really tight, and that can actually clamp down and cut it off, as well as the clavicle. It can be a genetic thing, or the clavicle is not moving properly. There's an injury, something I've seen it under ultrasound where it actually clamps down on the subclavian artery, so people can't bring their arms back when they're in this position, saying trying to do a back squat. They start getting they lose color in their hands, which is telling me more of a vascular, because that subclavian artery, or it can even be a nervous thoracic outlet syndrome, often called TOS. So those are some things that we want to look at in here that could be causing things further down and into the hands. All right, so next, after we've ruled out the spine, looked at the shoulder, we're going to talk about, there's a distribution that runs on the inside and it goes into these fingers. Now, a lot of you are probably right in here. A lot of you are probably familiar with this one. We call it the funny bone. When you hit the funny bone, you get that electric shock down your arm, and sometimes you get some residual numbness in these fingers. So a common entrapment is the cubital tunnel can entrap, like I said, the ulnar nerve, and I'll put some pictures up. The cubital tunnel, and another one to look at more distally is the tunnel of Guyon, is another one that can mimic the cubital tunnel syndrome, where that ulnar nerve can get irritated and cause that numbness and tingling or even pain into these fingers. Okay, so this next one is a big one that a lot of you have heard of, carpal tunnel. People throw this around like they throw around the term sciatica, and now that's a whole nother video, but the carpal tunnel, they're like, I have numbness and tingling in my hands, I think I have carpal tunnel. So there's a little bit more specifics that we need to go into. So what's getting entrapped in carpal tunnel syndrome is the median nerve. As it goes right through here, there's a band called the flexor retinaculum. And that median nerve gets entrapped, gets irritated, a lot of times with people that are typing and doing repetitive motions, because all these finger flexors go right through here. But you can get some irritation of that median nerve. So what they do surgically, and I'm sure there's a lot of other surgeries, I'm not a surgeon, but typically they'll go and they'll cut that flexor retinaculum to let out the pressure, because the constant repetitive trauma, just from simple things like typing, causes fluid and inflammation to build up in there. So then you get numbness and tingling in this finger, this finger, this finger, and a little half of this finger, sometimes the back of these fingers. So a big thing with carpal tunnel syndrome, if that's truly what it is, so it's getting entrapped here. So the radial nerve innervates this little part right here. So if you have numbness, pain, or tingling into these fingers and the half of this finger, but you don't have any pain out here, it could potentially be right in here, that carpal tunnel. Another way to test it is you can literally just tap, and if that causes those pulses to go into your hand, you might have carpal tunnel syndrome. Another thing that often gets overlooked, and I've seen this a lot, when I was at the military base that I previously worked at for my internship, there was someone that actually had both hands. They had carpal tunnel surgery where they cut that flexor retinaculum, and after the surgery, after the recovery, they still had numbness and tingling. So this could have been prevented with a very thorough evaluation, because what it was is, while it looked like carpal tunnel syndrome, it was Pronator teres syndrome. So I'll put that up on the screen as well. But the Pronator teres can also entrap that median nerve up here. So pronator, what I like to think of as supination is like this. I'm holding a bowl of soup. Pronation is, think of it like a professional NBA player holding the basketball. So pronation right here, there's that muscle that pronates from here to here, and it can entrap that nerve, and it can mimic carpal tunnel syndrome. This is huge. That patient that I was telling you about that got the surgery, I actually just did a couple muscle passes, and in one treatment, completely gone, no numbness. After they've had that flexor retinaculum cut, that anatomy is never going to be the same, and all they needed was some muscle work in the forearms. All right, so the last two don't really follow those rules of the typical nerve patterns necessarily, and those are nutritional deficiency and drug side effects. So it could be your medications doing side effects causing numbness and tingling in the hands, burning sensation. So if you are having those, talk to your medical doctor, see if that could potentially be a side effect of the drug that you're on, or you could have a nutritional deficiency. So sometimes when I'm like trying to piece together the puzzle, I'm like, something's not adding up. It could be a simple nutritional deficiency. You take a supplement or you try to get that through your diet, and then those issues start to go away and self-resolve. So those are typical things that we see with numbness and tingling in the hands. Now, don't hear what I'm not saying. Can there be other crazy exotic things? Yes, but clinically this is what I see the most of, and that's what I break down in my head, ruling out the spine first, working my way down, and if I can find and reproduce the symptoms by moving the body a certain way or pressing somewhere, I can likely find what's actually causing the issue, and we can correct it before permanent nerve damage takes place. And one little plug, if you're like laying in bed, or I'm like, I have my arm up here, or in certain positions, there can be a positional component as well. So if you just say you're sitting in a certain position for too long, it starts to go numb. Don't think it's the end of the world. If you get out of that position and goes away, it's likely not a big issue. I'm more worried about the long-term numbness and tingling that's repetitively happening. But I just wanted you guys to be aware of that, because some people were like, yeah, like I had my arm in this extreme position for 4 hours and it went numb. Don't do that. So if you made it this far, I'm guessing you enjoyed the video, so go ahead and smash that like button. Anyway, if you guys enjoyed this video and you'd like to see more videos like this, just let me know. I really enjoy making these videos. I try to make this video as informative as possible, but not over the top, because I wanted everyone to understand it so that you can start piecing together that clinical puzzle, take your health into your own hands, and figure out what that next step is. So first thing you need is a definitive diagnosis to know exactly what the issue is, and then you can proceed at correcting it, whether that's conservative care, changing your activities of daily living, whatever it is. But yeah, I hope you guys enjoyed. Hope you have a good one. All right, I'll talk to you guys later.
Yeah.